Hello and welcome to today's webinar. We are excited to have Matt Ethington and Cody Burkhart here to discuss optimizing chronic care management and remote patient monitoring with Chronic Care IQ. My name is Caroline Willie. I'm a marketing operations specialist here at Veradigm, and I will be your facilitator today. Before we get started, let's go over a few housekeeping items. We are recording today's webinar, and all attendee lines are in listen-only mode at the start of the session. There will be a Q&A session at the end of today's presentation, so please submit any questions that you might have via the chat window. Let's go ahead and get started. Matt and Cody, the floor is yours.
Okay. Thank you, everybody. My name is Matt Ethington. I am the founder and CEO of Chronic Care IQ. The reason I became a founder of medical technology in the first place is because at the age of 30, I was diagnosed with type 1 diabetes in the emergency room. Um, and I was made aware that I was days and maybe hours away from being in a coma. So I had to learn how to manage a pretty serious chronic disease. At a late age for type 1s, but as a young age for an individual. And because you have to take shots and poke holes in yourself, that type of thing, it requires a lot of discipline to manage. So I was specifically drawn initially to electronic medical records technology because I wanted to be closer to doctors. And this was in 2000. And then when care management reimbursements started becoming a thing and they introduced reimbursements specifically for it in 2015, I became very passionate about it. So the Chronic Care IQ, who are we? We're going to go over that in our agenda. The problems that we can help practices solve in running care management effectively is what we've learned over the last 11 years, having now helped practices, I think, achieve greater than $400 million in reimbursement and over 400,000 patients under management, et cetera. We're going to go over some of those today and just give you a highlight of our tools. I would encourage all of you, if you're thinking about doing care management, don't just think, well, Chronic Care IQ has an interface with Veradigm and we're going to go take a good look at what's out there. You'll find, I think that what most people have found is that uh, our maturity in the market and our ability to help so many practices succeed has given us, with founder bias, the best set of tools. But everything is always most about what's right for your practice. And then joining me today is Cody Burkhart. He is our marketing director. We call him the digital mad scientist. And when he came aboard and joined our team, his theme, and now he has a team, is we're going to tell our customer stories. We're not going to tell our stories. So everything that we do and talk about here is backed up with facts, credibility, over 600 practices, thousands of doctors, 400,000 patients, and hundreds of millions of dollars in successful reimbursements, audits, etc. So, Cody, could you take us to the next slide, please?
Absolutely. Thank you for the introduction, Matt.
You bet. All right, so there are three things that I want everyone to remember, right? So if you don't, if something takes you away or I'm boring you to death, please don't forget these three things. Medicare has no choice but to fix or address the evolution of chronic disease. It's really a champagne problem, right? We have people living longer, investments in public health and vaccinations, et cetera, mean all Americans are living longer. And we also have a demographic change or migration where we have boomers, right? 10,000 people a day for the next 14 years are turning 75. So the domain of the elderly, domain of chronic disease is primarily the elderly, the Medicare population, and we are living longer and we're experiencing more chronic conditions and more people that are of the age to have them. So it's a celebration kind of our public health initiatives, but it means we've got a new one to address. It is not a subset of healthcare. 4.3 of the $5 trillion Americans spent on healthcare last year is tied to chronic disease. It isn't a problem, it is the problem that the American health business health system faces. RFK Jr. said in a video right after the Super Bowl that chronic diseases are bankrupting America, and it's the same thing that I had heard from a colleague who lives here 10 years ago and was an undersecretary of Health and Human Services at the time. Said they don't just break Medicare, they bankrupt the entire U.S. currency. So you're seeing all these initiatives like ACOs and pushing towards from providers down to mid-levels and moving operations from hospitals to lesser expensive surgery centers and um, different type of payment uh, plans and shared risk, et cetera. It is all about cost, and cost is tied to utilization. And the connection that Chronic Care IQ made was that utilization is tied to human suffering. So when we can back it all the way up to the patients that are experiencing disease progression, then we can start to stop the problem on the front end instead of the back end. And that's where we come into play. But chronic care is a different type of care. It's what happens between visits. Most of chronic care happens between visits. It's the medication changes, the refills, the care coordination with three other doctors. It's the reconciliations of 7 or 8 different medications or 12 medications that the patient's taking. It's loved ones calling in saying, "Mom's really tired today. What should I do? Blood pressure's up, blood pressure's down. Should we go to the hospital? Should we do that?" And there's so much work, so much extracurricular activity that is either not reimbursed at all, which is what happens in most cases, or it's under reimbursed. So Medicare set up in 2015 a way to encourage practices to participate more in these activities, but also get practices paid for this work. And they did it by setting up reimbursements based on the amount of time that not just the doctor spends on patient care between visits, but the staff spend on patient care between visits. You are already doing most of the work required for chronic care management. It is not a 20-minute phone call from a call center documenting a few things on a template. It is the amount of time, it doesn't even require a phone call. It is the amount of time that your staff spends on patients between visits. And if you're going to try to do chronic, if you want to participate in the reimbursements and you're going to do it manually by tracking things with a spreadsheet, et cetera, you will find, as we found, having implemented over 1,000 practices, that it's death by 1,000 cuts. But success comes with automation, and we'll go over just a little bit of that. And I believe, it doesn't mean that you should believe this, but I believe, having worked with thousands of practices in the last 25 years, understanding ambulatory workflow, and certainly understanding the evolution of the now 30 monthly reimbursement recurring codes that you can earn for managing patients between visits. And this is in addition to all other episodic revenue, right? So this is in addition to all the other E&M coding. But it is probably the most tangible opportunity to earn high margin extra revenue without a huge impact on the practice. And that's because, again, you're probably doing most of this work. So care management programs should actually be a profit center in your practice. They shouldn't be break even. If they're break even, you could be doing something, could be changed, tweaked, whatever, and it could be doing better. So next slide, please, Cody. All right, so this is our current state, and the reason that I throw these numbers is we're one of the largest, but it is to give you some reassurance that we're credible. So today, and that was as of this morning, 411,967 patients have been enrolled by practices in Chronic Care IQ. We have Ascension data. It's a couple years old, but it was a 3-year retrospective analysis, and it showed a 29.4% reduction in all-cause hospitalizations on patients that were enrolled in Chronic Care IQ. We have we do so much internally in our platforms. We track the reimbursements that practices should be earned, so you can get the billing codes at the end of the month. Nobody has to go and manually calculate all of that. So we know how much the reimbursements we've generated over $390 million in reimbursements for practices in 14 specialties. And we've automatically tracked over 3.5 million hours of staff activities. Automation and passive collection is key to care management. Everybody in the office already has something to do. So as much of this, the scut work, if you would, around documenting, collecting, tracking, etc., when you can automate that, you can participate more fully in these programs. The average, and I don't know how many tens of thousands or hundreds of thousands of provider months that we now use to calculate this, but the average per provider per month top line reimbursement is $13,503 in net new recurring revenue. So that's what these care programs generate. Some are much, much, much larger, and many, like we have cardiologists that don't even bill. They're like, we just need to know when patients are in trouble between visits, and then we'll do all the rest of that stuff. This next number is my favorite, right? Because there's so much cost in keeping a doctor seeing patients. When you're in care management and staff time can now generate revenue, they become resources, not expenses. So we track all of the time because we have to track all the reimbursements that we tell the practices they should bill for. But because we track all of it, we have really great data around it. For every hour that somebody is inside of our platform managing patients, they're generating $131.95 in revenue. So when you think about MAs that are 20, 25 dollars an hour, nurses that are $45 an hour, they now represent opportunities for your practice when you're ready to take a deeper look and say, is this something we should or shouldn't be doing? Next slide, please, Cody. All right, more of the stuff I've already told you, right? But these are some good names just meant to establish for you that, hey, there's credibility here, there's references here. And so this, we're not coming out of left field with a great idea. These are actually implemented across America. Next slide, please, Cody. So Chronic Care IQ is designed to track activities that are taking place already in the practice, engage patients so that they can provide updates to their practice. So you're passively collecting patient status. And all of these programs, with the exception of TCM and APCM, have a time component in their reimbursements. RPM, as many of you probably know, is like, am I getting blood pressure readings from my patient or glucose readings or weight or something like that? RTM is something a little bit different. Am I getting subjective readings from my patients? So those are based around the amount of readings that you're getting, but they also have additional reimbursements when you can show that your staff has spent a minimum of 20 minutes of non-face-to-face time on clinical activities. So it was easier for us than most others to track all of these different codes. Like behavioral health is prominent in FQHCs and large internal medicine groups. PCM is CCM for specialists. APCM is no time tracking at all. It's just enroll your patients, keep them engaged, engage with them digitally, and you can generate, I think it's $60 a month on those patients. So we support all of the programs, we track all of the information, and we can delineate directly to which program would best fit that customer's reimbursement structure that month. So we're able to optimize them because we do all of them. We enable you to do all of them. Next page, please, Cody. All right, so here's the reality. What separates you from care management? There is a huge amount of care management activities already taking place in your practice, right? So if this was so great and we're all already doing all of this work, why is it that only 20% of the Veradigm network and 14% of physicians overall participating in these codes? Because the reality of the practice is it is a grind. In your Everybody already has a job and there's already many more things that they can be doing, right? For for every I may have a patient that I'd like to talk about care management with, but I've got 5 messages that haven't been answered. I got 3 patients waiting in the exam room. I've got 2 in exam rooms waiting for the doctor. 3 lab results have just come in, and the phone's ringing. So there's already really, really compressed and pressurized practices. So when somebody said, "Hey, you could do this, 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 and this, and make a little extra money," well, the extra money is there, but I can't stop doing my core business to view care management and engage in a little extra business. So those have been our learning lessons since the day we rolled out our first customer, who's still with us, by the way, in 2015, is you have to get systems that work within existing practice workflows. You've got to heavily automate, and you've got to treat it almost like a service line versus just an extra subset of care for a few extra codes. Um, so that we're seeing uptick, right? The first reimbursement code came out in 2015, and it took 10 years, to get to 20% of the Veradigm professional network. But it's it's moving up quickly, much more quickly now, but largely because there's so much money in it. But next slide, please, Cody. So this is just an idea. Like this is a real practice. It's ours. We delabel. It's a 2 doctor practice. This isn't really that large, but it shows you that of these patients that are enrolled, they anywhere from 99 to 74% of them were billable, and the projected billing amounts were anywhere from 100 to $79,000. That's a lot of extra revenue for a 2 doctor practice. And that's primarily because caring for these patients is a lot of extra work, right? It's not came in for a physical, I won't see them till next year. It's the phone calls, it's the care coordination, it's talking to the cardiologist, the pulmonologist, the nephrologist, the uferologist. It's the daughter or the son calling in. It's finding out that they're in the ED or they're in the hospital, and then we have to do the med rec when they get out of the hospital. And so much work is given away. And the good care that good chronic care provides, when it's reimbursed, it's great revenue. $103 is the average monthly reimbursement of the patients that are enrolled in Chronic Care IQ. If you're already thinking about this, we don't participate in reimbursement, right? We charge a flat fee per month, so our practices accumulate, they get to keep that. The reason it's $103 is because on average, 73% of patients are billable. And we're not a call center where we call your patients and we're pushing to make everybody billable because we're participating in revenue. We're a platform that enables you to provide a higher level of care to chronic patients and get paid for it. The reason, the actual per patient reimbursement, so per billable patient, the number is $153. But when you add up all the patients that aren't billable, it brings it down to 103. So there's 2 averages: 153 for patients that reach at least 20 minutes, and then 103 for all of the enrolled patients, period. Next slide. And view that as not like, oh, I'm going to make a bunch of money, but view it as the scorecard. That means 73% of patients are achieving extra revenue for the practice, mostly for revenue that you're already doing. So what all this means is that if you're performing chronic care management services and RPM services and behavioral health well, it can be less work for your practice. It is new, high margin, recurring revenue. Recurring is important, right? It's a lot easier to be a software SaaS company because we make money whether we sign up a new customer this month or not, right? In most of your practices, the doors have to be open and we have to be turning those rooms and seeing new patients every month. If you had $30,000 or $40,000 a month coming in automatically for patients that didn't have to show up, it would make things a little easier. And we've shown better outcomes, more profitable programs. Patients are very sticky. 87% of patients that start participating are still participating in a year. And here's why. So I'm going to dive right into the things that we do. We're 20 minutes in, and I wanted to only be 15 minutes in. This is a summary of how we do it. And of course, you can get much more information from us. We already have all your Medicare data. We already have how many patients would be eligible for you. We can create a pro forma that's nearly perfectly accurate, like in a snap. But let's go to the next page. This is how we do what we do. The first thing is we invite the patients to participate, right? We don't say every patient that's pre-hypertensive and has high cholesterol, we don't encourage you to enroll everybody that's a profit opportunity. We encourage practices to enroll the patients that would benefit with a few extra eyes on them every month. So the way that we engage the patients is very non-invasively. We simply send them a message, or we send their children a message like, Nancy, is your mom short of breath today? Is it better or worse than it was yesterday? Or Mrs. Johnson, when was the last time you were dizzy when you stood up? Have you had more good days or bad days this week? And those questions that we ask, the frequency that we ask them, and then how we score them longitudinally, we call those clinical monitoring protocols. We didn't invent them. Our doctors and mostly our nurses invented them. And you can think of them as the questions a patient gets asked when somebody's managing them or checking in on them. And what we found was that a lot of our patients have high anxiety. A lot of these patients, I've been really sick, so I never felt like this would be um, a surprise to anyone, but it surprises a lot of people when they join us that 80 to 90% of patients will engage every week. And it's not because we have any magic, it's because the right patients are enrolled, right? If somebody's had a heart attack and they're now out of the hospital, if they're newly diagnosed with this medical condition or that medical condition, the thing I always felt was I was isolated after I was diagnosed, and a lot of this experience went into building this platform. It wasn't that I had plenty of people that loved me, right? I have a big family and they cared about me, and that's nice, but it's not the same as talking to your nurse when you have anxiety. And your nurse is like, look, this is kind of normal. It's not perfectly normal, but you're not dying. And we're going to be able to check in on this next Monday or Tuesday, this weekend, or do this, or um, for the next 2 days, like don't eat bananas with your breakfast anymore, right? Try to focus on something a little bit more protein based, things like that. There These are patients that have big concerns, and many, many, many of them are waiting for the other shoe to drop. And we're not just talking about young people like me, who was 30 at the time. We have, when my mother was diagnosed with pancreatic cancer, she didn't want to be a bother to anybody. She's got, a daughter who is going through a pretty rough divorce. She's got her son and daughter who are professional and very busy. She's a caregiver to her husband who has dementia. And, there's another sibling in the family that's kind of failure to launch. And she was so worried about bothering everyone else. And we get that, right? We get that as with our loved ones, our aunts and stuff. They don't want to bother people, so they kind of suffer in silence, and they don't want to press four buttons to talk to the right person and go over the same story again and again and again. So having that ability to check in, say, Mrs. Ethington, have you had more good days or bad days this week? And have that automated and be in a non-invasive way for the patients to reply, they will reply. Now, we do have patients, of course, that are beyond any technology utilization, in which case our platform, because we know a lot with AI about these patients, what we need to do, what we should be probing for, we do not make diagnosis or anything. We're just trying to highlight the ones that need clinical attention. They need somebody to determine whether this is important or not. So those protocols surface those rising risk patients so that your staff can engage them. And for patients that don't engage with technology, it can even tell someone that works for your practice who to call, what questions to ask, and when to call them. So you don't have to put a highly skilled, highly paid nurse on the phone or a busy MA that's already in the practice and rooming patients. You can take a um, a lesser skilled but ambitious and obviously intelligent person and say, hey, we want you to help with this program, and then you can follow those patients. Some of our practices simply don't engage phone-based patients. They're like, it's a digital monitoring solution. That's how we use it. And I think that you should, as you're evaluating our platform and other platforms, is look for proof from the patients and look for proof from the doctors. Medicine is famous for selling stuff, right? Hungry people selling, I don't know, like, I remember there was a big movement to put antibiotics and sell pharmacy from your practice, or uh, laser hair removal. It seems like there's always something new to try to talk you guys into making a couple extra bucks. So the way you get around that is, like, you want real reviews. You want to talk to real people. If you go to the App Store or the I'm not an Apple guy, so the Apple App Store, go to the Google Play Store, you can actually see how do patients are patients using this. And it's remarkable if you think 800 patients 65 or older have not only given us 5 stars reviews on an app, but have actually written what they like about it. So make sure you're vetting your vendors on customer and patient satisfaction, because the patients are key. If the patients don't engage, you don't have a platform. It's optional. If they won't participate, it's over before it began. All right, so benefits, right? Um, when you're running a good care management program, you will see reduced phone calls and messaging. You'll see increased patient access. If they can answer questions um, easily, that kind of that that um, fixes that urge to, like, have anxiety and be worried about things, etc., and not know, and should I call, should I not call. It builds a lot of patient confidence. Instead of heading to the emergency room, you'll get a call first, or you'll get those things, and we like that, right? Creates stronger relationships, and we see that over and over and over again, and it dramatically improves patient quality of life. Cody's going to go over some of these case studies. We have, I don't know, 20 plus case studies, and we always pull out one of those hero stories where somebody did something and it was amazing, and this patient would have gone to the hospital, or there would have been an event, and those are great. But those patients that are experiencing changing life conditions, disease progression, they don't know what to do. They don't know how to navigate healthcare. They're just not a little bit overwhelmed, just knowing that your practice, because they think somebody typed up these messages to them, right? So a lot of times they think somebody's directly reaching out to them. It improves their quality of life, right? It really does. It allows them to have more confidence to live bigger lives. And again, 87% of patients that start are still engaged after 12 months, and that's why. And the results show it. So the next thing is, like, what do we do with all that patient engagement? If you could go to the next slide, please, Cody. So we asked those questions. Have you had more good days or bad days? What was your fasting blood glucose this morning? Have you seen any new doctors or started taking any new medications? The There are over 600 of these disease management protocols. And what they do is they've configured questions based around primary, secondary, tertiary diagnosis, looks at how many medications the patient's on, et cetera. And then what we learned over time is that if I can get a few answers, few data points frequently from a patient, it's better than a lot of data points infrequently. So we're able to dynamically risk stratify these patients. We we consolidate and we collate all of that inbound patient data that is analyzed through these protocols longitudinally and based on what they're specific, how they answered today. And then we can define them red, yellow, or green. Red would indicate that the patient has exceeded a preset clinical threshold. And it's basically telling somebody in the office, like, hey, this patient probably needs somebody's attention. Yellow means that the patient's trending in the wrong direction. They could be newly trending. They could be trending for a while. If they're trending for too long, they'll turn red. And green means that the patient's checked in. We don't see anything screaming for attention. So for the first time, you can have situational awareness of the patients that need your attention and and specifically the ones that need your attention relatively soon. If any of you are in risk-based contracts, this is a secret weapon, and it tilts the odds massively in your favor. We see that again and again too. So being able to have situational awareness of who's at risk changes the game in healthcare. Again, this is, don't enroll all 2,000 of your patients that one doctor has. You pick the ones that you think will give you the greatest impact to do something different. Next slide, please, Cody. The following that, right, when I click on one of those red patients, I then get actionable intelligence. Why are they red? What's been trending? How long has it been trending? You see heart failure patients gain 3 pounds in 24 hours. We learned, right, the standard of care is 2 pounds in 24 hours. We learned in Jackson, Mississippi, that it's possible for almost anyone to have a 2 pound weight gain in 24 hours, right? We also learned that in San Diego, California, it's almost impossible for anyone to have a 2 pound weight gain in 24 hours. So there are tweaks, et cetera, to these protocols, but you'd get to dial into risk. And the whole idea here is, why is this patient at risk? Because when we bring it to a physician and he can see how blood pressure has been trending up for how long, or how weight gain happens suddenly overnight. Have they noticed new swelling? How you because these questions configure themselves based on symptoms, and then we can see, okay, this happened in a hurry, right? All of this weight gain was within the last 24 hours, or this blood pressure has been sneaking up. Here's one we catch all the time. Patients go home from visits, their fasting blood glucose was one level, say 140, which isn't perfect, but it we're not going to completely go off the rails about 140. Within 30 days, they're consistently fasting around 220. That is a problem. And with type ones, for example, they you don't mind a one increase in fat. I'm not going to freak out about if my blood sugar is 240 one morning, because I can adjust it with insulin. But if it's 2 mornings in a row, that means there's an infection somewhere and something's going on. And it would be great for my doctor to know that. I know what to do with it because I've been managing it for 25 years. But that's the kind of intelligence you start to get on these patients, and then you can prevent adverse events, which is the things everybody loves to talk about because they're the hero stories. But it's also slowing or halting disease progression, right? So one disease doesn't turn into 2 to 3 to 4 to 5 to 10 medications, and we get way out of stasis. And it becomes harder and harder to manage these patients, and they suffer a lot with it. So it is situational awareness, actionable intelligence, and then Cody, could you help us next? The rest of these things, they become part of the business model. These are time-based reimbursements. What are your staff doing when they're not in the room of the patient? They're probably in the EHR about a patient, or on the phone with or about a patient. So the time, the non-face-to-face clinical time that takes place is what we're tracking in our platform, but it's the work you're already doing. So we started something a long time ago. We called it Caller IQ, and we were just looking at caller ID logs, right? Let's throw out the non-clinical extension. Let's only track the enrolled patient, and let's throw out the whole time, and then we'll just aggregate it, and we'll add that time up, and we'll drop it into the audit log at the end of the month. And what we've learned with Caller IQ, it's not only that, we can spot rising risk patients, especially across enterprises, by the changes in frequency and longevity of phone calls. And so we might even suggest to a care manager, hey, somebody should call this patient and see what's going on. But it is a huge lift to your care management programs when you get those, when you plug in Caller IQ, because it's not going to track the time of my dad arguing with the biller about $3.76, but it is going to get the time that I went to the front desk, I was transferred to an MA, and then I was transferred to the nurse, and the nurse left a message, and the nurse called me back. And all of that then gets collected and dropped in. So That's a power of caller IQ. If you're doing a CCM and or RPM program and you're not plugged into something like this, you're it's almost it's a huge opportunity for you. Can we do the next one, Cody? So billing IQ, I love this, right? When you have 30 reimbursements that depend on different activities, time collection, when you could be in our platform, when you could have the chart open and you could be on the phone with the patient at the same time, and you have a certain amount of time that a doctor is doing things for a patient, and then you have a certain amount of time that nurses, when you can quantify and qualify all of the time, and you have a computerized system that looks at that, it prevents overlap, and it can also drop the patient the right billing codes for the right activities. It's not something anybody can do manually. For example, 3 instances, an hour of time spent on a patient with 2 or more chronic diseases. That could be a complex chronic care IQ code that pays a certain amount, but it could also be billed as 3 non-complex 20-minute codes. And a lot of people say, oh, well, bill complex. If you want to get an extended complex code, then you have to have another 30 minutes. But if you want to add another 20-minute code, then you can add a different type of code. So not having to worry about that and getting all of that information is important. It protects you, right? Obviously from audit logs, but it also protects you from undercoding and overcoding. And we have an entire rules engine around this. We have been audited over and over and over for the past 11 years. And I'm happy to say we it hasn't caused any problems. We've never lost an audit. Our customers have never lost an audit. Uh, Cody, the next one. And this one actually should have been the one prior. It's called Audit IQ. And Audit IQ is every piece of time that we capture, whether you're in our system, whether you've done something in the EHR and it's time stamped and we've captured that, whether you're on the phone, whether somebody sent the patient a message, whether you've listened to a message, all of those things land in the audit log. And the audit log is a by the second directory of the time spent and the activities performed for these patients. Then we can make sure none of it overlaps. We can see who did it. We can track it. And it is the audit ready log that informs billing IQ. So that's why I wanted to show audit IQ first. It tracks everything. And so it's really hard. You have to manually and purposefully change a code that our platform has recommended to not be audit ready for your billing. So the billing IQ is fed from audit IQ, and it doesn't let you code for something you don't have documentation for. These are business tools, right? If you're going to do this at scale, if you're going to run care management, you have a lot of patients chewing up a lot of extra activity that's not getting reimbursed. And to do 4 or 5 patients is not a big deal. To do 4 or 50, it becomes something. But when you're doing 4 or 500, then you want to automate this. It makes it a low impact. The Veradigm CCIQ integration is world class. These are all of the things that Veradigm sends us, and these are all of the things that we send back. So it's a single sign-on. You get started. It embeds. You don't ask people have to log into 2 different systems, etc. If you want to learn more about that, we can obviously take everybody through more of those types of things. Cody, I should be done here pretty quick and let you talk about customer successes. And thank goodness I am, because the problem is I'm so passionate about this product and the results and relieving suffering that I can talk until it gets dark. So this is Cody. He's going to tell you about case studies and his approach to marketing.
Thank you, Matt. I appreciate that. So, I'm the marketing director for Chronic Care IQ, and we always get excited when we get leads, when we get sales. But one of my favorite parts of my job is actually just being able to go get some time to spend with our clients and some of their patients. We get to hear about all these wonderful stories that we just otherwise wouldn't be able to get access to. So it's really nice to be able to go hear the impact that our product can make with the lives of our patients. So just to go kick that off, we had a client of ours called Home Physicians Group. They are a fairly large practice, and they actually came to us because they were looking to go consolidate their CCM and RPM programs into a single platform. They were actually doing half of these with one tool, half of them on a spreadsheet. And so they came to us because they wanted a consolidated platform. So they were actually able to go triple their patient panel without adding additional staff headcount. And we've heard this from a number of our clients that they can actually scale up their patient to care manager ratios and actually spend more time with their patients. So that's just really, really incredible to be able to hear that. That's just how much more efficient they become once they actually start using automation via CCIQ. So they actually had over 2,200 patients enrolled into these different programs. And as Matt talked about earlier, our average is about $132 per hour in reimbursement with time spent in our platform. Home Physicians Group actually exceeded that, and they were hitting about $160 per hour in reimbursement with time spent in our platform. And they told us about a really powerful story where they had a heart patient. He was not very great at managing his health. He was very, very new to being more proactive in managing his health, and he had to go start wearing a blood pressure cuff that was feeding information into CCIQ. And within just a matter of a few weeks, actually, just only a few weeks, they realized that something was really wrong with the data that they were collecting between the blood pressure cuff and between the check-ins that he was doing with our app. And they had him come in for further examination, and they realized that he needed a pacemaker. And they told us directly that without being able to see that information in his trends, that this very easily could have become a critical event. But he was actually able to get pacemaker, and is leading a healthy, normal life now. We also work with National Jewish Health. This is a massive, massive health institution. They're internationally recognized. And as Matt was talking about earlier, this is obviously a very, very large profit opportunity for practices. They're generating, National Jewish Health is actually averaging about 101,000 in monthly reimbursements. And that's off of 1,064 patients enrolled between CCM and RPM. And they are very heavy users of our platform. They're spending 660 hours per month of inside of our program between their staff. So very heavy users. And they actually shared a story where with Risk IQ, they were able to detect a patient who was literally in the middle of having a stroke. The person actually happened to be at the hospital for a completely unrelated issue. And they actually called him while he was in the hospital, letting him know that you're having a stroke right now. And they actually had to go completely change everything that they were doing with the guy inside the hospital. So really, really cool story to hear that.
Cody, can I add something real quick to
Yeah,
National
absolutely.
Jewish? So National Jewish Health is in Denver. They are one of the top five pulmonology clinical research facilities in the world. They are the only health system other than the Mayo Clinic that will accept and admit a patient when they don't know what's wrong with them. So the patients that they receive and that they care for are super highly complex. So they're monitoring a lot of data points on these 1,064 patients. They grow by about 10% a month. So it's getting a lot of great press over there. I just can't talk about this enough because I have to run this business. We have MAs. They cost what, $25 an hour fully loaded, 20, 30 some places. You're changing that cost margin, being a 30 at dollar an hour costs into $177 an hour revenue generator. It is no longer just providers that can generate revenue for the practice, right? And this is for work that you're already doing. And of course, National Jewish has these incredible protocols and focus on it. Some of their patients, go back home to other places in the country and they still keep tabs on them. So very highly clinically motivated team, and they're cash flow positive and uh, growing more and more every month on the platform.
Thank you, Matt. So now we have a final story case study in here was we have a client of ours called R-Care. They are a large regional healthcare practice. They have 100 locations over three different states. They've got over 3,500 patients enrolled in between CCM and RPM, and they generated about $800,000 in additional reimbursements last year. They actually let us know that they were averaging about 100 to 150 patients per care manager before us, and they were actually doing their entire program through a spreadsheet. And after they implemented CCIQ, they were able to handle anywhere between 350 to 400 patients per care manager, and that they were actually spending more time with their patients with that higher patient load than they were when they were using the Excel spreadsheets. So really, really impressive. And they let us know about a patient who was actually, they detected via Risk IQ that they were actually accidentally overdosing. And it was a very simple mistake where this person was prescribed medication that they were supposed to take throughout the day, and they didn't want to forget. And so they started taking all of their medication all at once in the morning and was actually started accidentally overdosing. And so via the data that was being collected on our patient apps and the check-ins, they realized that there was a problem, and they were actually able to go intervene and educate the patient on how to take their medication properly. So these are just three powerful stories that we have. We have an entire case study library full of all these different case studies, wonderful results that we've helped with our practices, and all these different patient stories. You can actually find them throughout our entire website, throughout the app stores that Matt talked about earlier. Like he said, there's over 800 reviews between these two different platforms of patients that are just completely on their own. Like we do not solicit these from our patients. We don't run campaigns to our patients about these. They're just sharing because they're so excited about the program that they're in. So please, take a look at these when you get a chance, and I'm happy to go share some links in our follow-ups after this webinar with our resources.
Cody, I'd like to make an important update. I'm close to R-Care. So the 800K that we pulled in here was from a presentation that we did quite a while ago. Last month, R-Care generated close to $400,000 in revenue. So they are sustainable. They're growing programs. It's an FQHC, 91 locations in 4 states. If you're serious about running a program, you want to find out how they did theirs. I'm sure they'd be happy to talk to you also. Big impact on patient care. Revenue is there. It's work you're already doing. It's exciting. But it is these patients that are home alone, not quite connected, a little worried. That was my experience. That's where I get the most joy. It's why I wake up in the morning, because everybody's got a loved one, an aunt, an uncle, a sibling, somebody that is probably going through a lot of turmoil alone in this type of care, or we could just make it easier for them. And that's why the patients love you, make it easier for them. And it's so highly profitable. So if we can be involved, we'd be honored to be involved. But I wanted to share that about our care. So if I had 3,500 patients enrolled and all I was making was 70 grand a month, I'd be pretty nervous. So it's 800 care was I think 4 or 5 months after they went live. So I thought I should share that.
Yeah, thanks for clarifying on that, Matt. I'll turn it back over to you.
So the thing, like what I said about the three things at the beginning, Medicare has to do something about chronic disease management. It is a champagne problem in healthcare. We're helping people live longer. More people are reaching the age where chronic disease start to happen more often, and uncontrolled, they create more episodic care and then acute care, and it's so expensive. So um, all, I don't know any other. I've been working in medicine for 30 plus years. I I don't know another segment where reimbursements have increased in value and also in number every year. So since 2015, with the exception of 2016, Medicare has been doubling down on reimbursements, increasing them, making them simpler to get or adding new reimbursements. So there's specialty care, there's episodic care, there's even non-provider care now in physical therapy and respiratory therapy. There are a lot of reimbursements. If you want to learn what your practice can do, we can run your Medicare data automatically and send you a summary. Um, so Medicare has to solve the problem. These aren't going away. They'll ultimately call this value-based care because it's what makes the difference. The second thing was you can do it. It's work you're already doing, but you can't do it manually. And it's not just hiring a call center to call a patient for 20 minutes. They drop out quickly. There's no recurring value. When you can move the patient into participating, they participate reliably, and then you get insights on a dashboard that keeps the nurses and the doctors engaged, and then you're tracking the data behind the scenes to make it operationally possible. You have to do all of them to fit it together and for it to be sustainable. The Medicare data also shows that when you're doing RPM and CCM together, you are 75% less likely to abandon the initiative because it shows a more organized approach. So when you're organizing, you have systems that help you. You can't do it. It's already revenue that you're getting. You just have to do the work to collect it now, and you should automate it if you want to be successful about that. So a couple things that we hear from administrators that patient referrals increase because old people talk about their health. Patient satisfaction goes up. Our own NPS score is above 80, right? That, and if you follow NPS, that's world class. It's unheard of. The average EHR's NPS score doesn't even approach 30. So patients like it. People like us. And then to do this, you're already doing a lot of it, but when you add the patient engagement and the patient monitoring, it locks it all in, it simplifies it, and the automation and the tracking make it operationally achievable. You can't tear your practice apart to do something else, right? It's got to fit in. And I feel like that's probably what differentiates us the most is the attention we paid to make it a viable business within the business. So we say chronic care simplified. Our mission is to relieve suffering. Cody, what did I miss? I've just been talking and talking and talking.
No, I think that we've covered it. I think at this point it's time to go turn it over for Q&A.
So if you'd like to contact us, we probably should have, well, we'll send everybody a follow-up. Uh, but my email, if anybody wants to write it down, it's well, you can go to sales at Chronic Care IQ. You can reach me at first initial M for Matt and my last name, which is on the first page that you'll get, M Ethington at ChronicCareIQ.com. We'll give you the straight scoop. We only charge by the month, so if you're not happy, we can't be happy. So we'll walk shoulder to shoulder with you and go at risk.
Thank you, Matt and Cody. So we're now moving into the Q&A portion of the webinar. So if you have any questions, please put them in the chat window at this time. Our first question is, how does Chronic Care IQ help practices prioritize which patients need outreach first?
Yeah, so that's a great question. Um, the reason that we do the patient engagement and that we have what we call protocols, which are automated surveys. Think of them as automated. So you push a question to a patient or in many cases, their daughter or their son, and we ask them questions. So if they say that they've had more bad days than good days the last and that combines with them saying, "I'm dizzy when I stand up," or some combination of how they've answered their questions, alert. They trigger in the protocol an alert to say, "Hey, this patient has exceeded a clinical threshold," or they were reporting different answers about these types of subjects last week or last month. So we measure their responses to questions through protocols. We've got 131.5 million longitudinal data points on these patients to determine, is that patient showing signs that they need some human attention? And we call it risk because if somebody's blood sugar or blood pressure is going up, that's a risk. But what we're really signaling is, hey, um, family practice of Mississippi, do you think that it looks like this patient might need some of your attention? And that's what we're really trying to signal is some clinical intelligence should be applied here. Does that answer your question?
Yes, thank you. Um, we're almost at time, so I'll go through one more question. But if we don't get to your question, we'll reach out to you directly after the webinar. Our last question is, how does Chronic Care IQ handle phone-based care activity and make sure eligible time is captured?
Uh, so we plug into the phone system. So if an outbound call is made to a patient, it is tracked. So the total time is exactly what you would need to support it in an audit log. Now, if you are doing this internally to your practice, you would want your documentation of those call-based activities should be done in your EHR. There are third-party companies that say, hey, use our platform and we'll give you questions that you should ask your patients. And we will basically it's a template, right? You're just trying to, a lot of these companies, we're trying to get this to 20 minutes through 2 10-minute phone calls. And we want you to fill out this, get these, here's 5 things you can talk about. Um, I like the Q&A is automatically documented in the audit log, our Q&A, the patient engagement, the questions, but the patient notes, they should be in the EHR. There are other platforms out there that they give you prompts, new prompts, um, and then they save it in their care management platform, not back to the EHR, which presents the risk of a shadow chart. I've been around for a long time. Then you have to make sure that if you're using one of those systems, kind of like if your doctors are using anything that is documenting the conversation in the care in the visit, right? And it's documenting the orders and it's documenting the visit and it's setting everything up so that when they leave the room, their visit is completed. If you're trying to take that same approach with, we're going to call a patient and I have a third party documenting all of these things through this phone call, that documentation absolutely has to land back in the EHR. Otherwise, it's a shadow chart and it's a risk. So that's how I would the call tracking time is automatically tracked, right? It's automatically done. You don't even have to think about it for anything. Even if they call in and they ask a question about something else, it's a care management activity, it's going to be done as well. But the note making and the note taking, we believe that should be done in the EHR.
Awesome. Thank you. Thank you, everyone, for joining us today. And thank you to Matt and Cody for presenting and answering questions. We appreciate your time and we hope to see you at a future webinar.
Cool. Thanks for having us.
Thank you, everyone.
Thank you.